Good morning. This is Lori Barton, and I'm going to spend a little bit of time talking about the anesthetic implications of selected medical disorders in pregnancy. Specifically, today we're going to be talking about infection and sepsis, and we're also going to discuss respiratory and autoimmune disorders. So let's start with some of the common causes of maternal infection and sepsis. Of course, you have to think about pyelonephritis, septic abortion, pelvic thrombophlebitis, chorioamnionitis always comes to mind, endometriitis, toxic shock, surgical site infections, especially in these post-cesarean section patients, pneumonia, appendicitis, meningitis, cholecystitis, and necrotizing fasciitis. Infection remains a significant cause of morbidity and mortality, but we're improving on our maternal survival. In pregnant women, sepsis is usually associated with gram-negative bacteremia, although it can be associated with gram-positive aerobic and anaerobic infections. So you always need to consider a polymicrobial etiology, especially if there's a pelvic source of the infection. So also of note, about 45% of the cases of maternal sepsis occur during the postpartum period. So just because the patient has had a delivery, you always need to keep this at the top of your differential if a patient starts showing clinical signs. So back in 1992, the Society of Critical Care Medicine introduced the definition of SIRS, which is the Systemic Inflammatory Response System, including sepsis, severe sepsis, septic shock, and multi-organ dysfunction syndrome. Specifically, they stated that sepsis is SIRS in response to an infection. Severe sepsis is associated with organ failure, and septic shock is sepsis with hypotension that is refractory to fluid resuscitation. And then, of course, understanding that the definition of SIRS is based on fever or temperature less than 36, a heart rate more than 90, respiratory rate, and then also looking at an abnormal white count. However, in the pregnant population, it is important to recognize that in a laboring patient, the traditional definition for SIRS is really kind of an unreasonable qualifier. For example, if you think about maternal leukocytosis, it can result from a normal labor process, and you also get a physiologic respiratory alkalosis in normal pregnancy, which might not be a compensation for a respiratory acidosis that might be associated with an infectious process. Also, you have to think about maternal tachycardia, which is often present during labor as well as labor pain. So thinking about traditional definitions and thinking of infection is really inappropriate in the parturient. So they've kind of come up with different categories to think about this. One is the modified early obstetric warning scores. I'm just going to keep the slide up for a second so you can look at some of these triggers. A second one that was developed was the maternal early warning system. Both of these studies, both the maternal early warning system as well as the maternal early obstetric warning system, had adjusted criteria to offer an alternative assessment tool for parturients. However, despite these new tools that we have, there's really little evidence to support the predictive value of any of these modified criteria in the obstetric population. Although they have not demonstrated a strong predictive value, they should at least be considered on a patient-to-patient basis whenever you're thinking about a patient who might potentially be having an infectious process brewing. So when you think about the Surviving Sepsis campaign, when they started this study, they focused on goal-directed therapy. However, goal-directed therapy for surviving sepsis did not include how pregnant patients differed whenever they're looking at their non-pregnant counterparts. So there's currently no evidence to show that this method of goal-directed therapy has any really survival benefit for pregnant or recently delivered women. Typically, for non-pregnant patients, the first-line vasopressor of choice is going to be norepinephrine, as we've learned, and this can be supplemented with both epinephrine and vasopressin to maintain adequate blood pressures. Glycemic control should be aimed at avoiding hyperglycemia with blood sugars greater than 180 milligrams per deciliter. However, realize that tight glycemic targets really increase your risk for hypoglycemia, so be aware of that and avoid hypoglycemia. Although the effects of maternal therapy on the fetus should be considered, treatment of the mother has to be the first priority. ACOG has stated, delivery is usually not indicated in a septic pregnant patient in whom pregnancy is not the source of infection. In cases of maternal sepsis and critical care needs of the mother, a multidisciplinary approach should be taken to determine the timing of the delivery. In cases of maternal arrest, perimortem C-section needs to be readily an option with an obstetric nurse, an obstetrician, a NICU team, and obviously the anesthesia team on board. And they have to be readily available for cesarean delivery in the ICU if that becomes the plan. So thinking about infection and neuraxial techniques, obviously you want to avoid neuraxial anesthesia in patients with overt clinical signs of sepsis. Specifically, you want to think about the sepsis and hemodynamic instability, and you really want to avoid having any type of analgesia that would produce a sympathectomy, such as neuraxial anesthesia. Further concerns of seeding infection causing meningitis also really has to be considered. The studies that have been done have really conflicting results as to whether or not bacteremic patients have an increased risk of meningitis after dural puncture. There's really a lot of flawed design studies out there. Multiple studies have been done that have not shown any increased incidence of meningitis following dural puncture. Also of note, these studies were looking at diagnostic LPs in non-pregnant patients, so we really don't have any good information in our pregnant population. I think most anesthesiologists would safely administer spinal or epidural anesthesia to healthy patients, realizing that appropriate antibiotic therapy might lessen the risk for meningitis or epidural abscess in patients with established infection. Also, we're challenged as anesthesiologists because we have to think about the risks of neuraxial anesthesia, but also we have to think about the alternate if we don't do neuraxial anesthesia, considering difficult airway and aspiration if general anesthesia is done for cesarean delivery. So we are going to spend a little bit of time talking about some respiratory disorders, asthma, obstructive sleep apnea, sarcoidosis, cystic fibrosis. But I want to make aware that I am going to skip respiratory changes that occur in pregnancy. I think Dr. Fragnetto does an excellent job in her lectures of this. So if you're looking for that kind of information, go to her PowerPoints because they're excellent. Also, I'm going to avoid all of the respiratory complications associated with different types of embolism, since I'm going to be doing a separate podcast addressing these concerns. So let's start off with asthma. It's a complication that is very concerning during pregnancy, since the functional residual capacity, or FRC, is already decreased as a result of pregnancy. So this makes further respiratory compromises, like during an asthma exacerbation, that much more challenging. Also, the increased minute ventilation and increased oxygen consumption that happens during pregnancy is going to further challenge the parturients. Interestingly enough, women who have severe asthma tend to have higher exacerbation rates during pregnancy, with most of these occurring during the late second trimester. However, about 23 to 30% of patients report an improvement in the number of asthma exacerbations, or the severity of their exacerbations during their pregnancy. So realize that asthma does not necessarily commit somebody to having more exacerbations or less during pregnancy. It's just going to be individualized. Although there's not a consensus on some maternal complications associated with patients with asthma, some that you have to think about are increased incidences of preeclampsia, hemorrhage, placental abruption, premature rupture of membranes, placental previa, preterm labor, and preterm delivery. What has really clearly been delineated with a large meta-analysis is that patients with moderate to severe asthma have an increased overall risk in their pregnancy when compared to parturients that do not have asthma. So when you think about fetal complications, these include increased perinatal morbidity and mortality related to preterm delivery, low birth weight deliveries, as well as small for gestational age infants. Finally, women with asthma are 11% more likely to have fetal congenital malformations. Of note, these malformations were not related to asthma exacerbations during the pregnancy or the use of inhaled bronchodilators. So realize that it's not the medications or the asthma exacerbations, but these women do have an increased risk of congenital malformations in their neonates. Also realize that pregnant women having an asthma exacerbation during their pregnancy are at a higher risk for preterm delivery and low birth weight babies. So medications should absolutely be administered when necessary and are considered safe during pregnancy. There is some controversy over oral corticosteroid use during the first trimester and an increased incidence of low birth weight and cleft lip neonates. However, corticosteroids might be life-saving for the mother and for the severe asthmatic and should be given when absolutely needed. During induction of labor, prostaglandin F2 alpha or copropose is used for cervical ripening. However, it's also a bronchoconstrictor, and its use during labor has been associated with bronchoconstriction. So make sure that you're keeping that in mind and having a good conversation with your obstetricians who might not be aware of how severe asthma exacerbations their patients have been having. Pain control in labor is important given that hyperventilation, pain, stress can all aggravate asthma exacerbations. So neuraxial anesthesia is going to decrease your oxygen consumption during labor. It's also going to decrease the work of breathing for the parturient and decrease minute ventilation. Prostaglandin E2 or Cervidil has also been associated with bronchodilation as well as bronchoconstriction. So the main focus for us anesthesiologists is trying to avoid general intratracheal anesthesia in cases where cesarean delivery is the goal, given the risk of provoking bronchospasm. You want to think about having a carefully titrated epidural or a low-dose combined spinal epidural might be preferable to just a straight single-shot spinal in patients with severe or poorly controlled asthma. So the effects of high thoracic epidural have minimal effects on pulmonary function in patients with severe asthma. You want to realize that though the vital capacity is going to be reduced by about 6%, total lung capacity is going to be reduced by 3.5%, and FEV1 is going to be decreased by 5%. The ratio of FEV1 to FVC does not change, however, and there's not going to be any change in tidal volume, gas exchange, and no change on ABGs are going to be seen after epidural is placed. If you have a patient where general anesthesia is completely unavoidable, you want to think about using drugs like ketamine as an induction agent, given that it has sympathomimetic bronchodilating properties. Propofol is also going to be a good choice because it's going to decrease the physiologic response to airway manipulation, decreasing your chances of having any bronchoconstriction. Muscle relaxants such as atracurium should be absolutely avoided due to the increased release of histamine. And you also want to be very cautious when you're thinking about your reversal agents such as neostigmine, which can cause bronchospasm, and you should always use these cautiously, as well as including anticholinergic agents whenever you give your neostigmine. In cases of hemorrhage, ergot alkaloids can cause bronchospasm, and hemabate or carboprost is a prostaglandin F2 alpha, and it also should be avoided. Post-op pain control with an epidural or epidural PCA or long-acting opioids such as Duromorph really are going to offer superior pain control to PO opioids, and they're going to help decrease the risk of exacerbation of an asthma attack due to less pain and less stress on the mother. So let's move on to obstructive sleep apnea. Due to the upper respiratory changes in pregnancy and further complicated by pregnancy disease states that cause increased upper airway edema, obstructive sleep apnea has to be considered during pregnancy. OSA has been linked to maternal complications such as gestational hypertension, preeclampsia, as well as diabetes. Fetal compromise is also a big concern, and it is demonstrated by parturients that have infants with lower APGAR scores. Diagnosis of obstructive sleep apnea by a sleep study is needed for definitive diagnosis. However, bedside questionnaires such as the Stop Bang questionnaire is not um, especially sensitive or specific for parturients. So although we often use the Stop Bang questionnaire in the pre-op area for patients that are having surgery, realize that Stop Bang is not necessarily going to be effective in your parturient population. CPAP is your treatment of choice, and it's been shown to decrease both systolic and diastolic blood pressure in parturients. CPAP is shown to be both effective and safe during pregnancy. Neuraxial anesthesia is the analgesia of choice, given the association of obesity and obstructive sleep apnea, as well as the increased risk of cesarean delivery in the obese population. Early neuraxial placement is warranted during labor. So realize that you might have some increased difficulty placing it, but the earlier you get it in, the better chance you're going to have of avoiding general anesthesia in these patients. Excuse me. In cases where you have to do a general anesthesia, anticipation of difficult airway should always be anticipated. You really want to not ever sacrifice your quality pre-oxygenation. The patient should be extubated only after they are fully awake and able to meet full extubation criteria. And in these patients, I oftentimes will get them onto their recovery bed, get them off of the OR table, and have them sitting in a fully upright position before I think about getting them extubated so that we can increase their FRC. This is also going to help if the patient would consider using a CPAP in the recovery area, especially if these patients are not compliant with CPAP at home, explaining to the patient preoperatively that CPAP use in the post-op is non-negotiable and is going to help with their recovery significantly. Most patients are then more compliant. So let's move on to sarcoidosis. It's a multi-system granulomatous disease that can cause tissue injury and granuloma formation. Realizing that the lungs are going to be most commonly affected, and they are affected about 90% of the time. Pulmonary manifestations are going to be a restrictive lung disease. You're going to have some fibrosis, you're going to see some bronchiectasis, emphysema, as well as pulmonary hypertension, which is one of the big feared complications. Pregnancy really does not typically affect patients with stable or inactive disease. Patients with active disease may improve perhaps during pregnancy due to the increase in circulating cortisol levels. But realize that postpartum relapse or the development of new manifestations is common at 3 to 6 months after delivery. Because sarcoidosis is typically benign during pregnancy, the focus of the anesthesiologist is pain control due to increased oxygen consumption. So let's move on to cystic fibrosis, which is an autosomal recessive disorder leading to production of thick mucus secretions by the lungs, pancreas, and sweat glands. CF patients are at risk for chronic infections, inflammation, plugging, and obstructive lung disease. They're also at risk for hemoptysis, fibrosis, restrictive lung disease, distal airway hyperinflammation, and pneumothorax. These all can lead to VQ mismatch and chronic hypoxemia, and ultimately pulmonary hypertension, cor pulmonale, and progressive respiratory failure. Patients with severe disease might not be able to tolerate the pulmonary changes that accompany pregnancy. So realize that these patients might be already at the edge, and then the complications of pregnancy and the respiratory changes in pregnancy might really make these patients very, very sick. The decrease in FEV1 during pregnancy correlates with poor pregnancy outcomes in these patients. So the anesthetic management for patients with cystic fibrosis are going to be early pre-anesthetic evaluation so that tests can be done and records reviewed. So you want to work with your obstetrician to make sure that they are referring your patients to you early enough so that you can get things like PFTs, cardiac evaluations, including echo exams, as well as arterial blood gases. when the patient comes in labor, early epidural analgesia is generally the anesthetic of choice to optimize that maternal respiratory status during those painful times of labor. Most anesthesiologists would choose slow dosing of the epidural rather than rapid or the all or none dosing of spinal analgesia. Slow dosing to adapt to the sympathectomy as well as getting controlled analgesia to T10 is going to allow for the safest and most conservative management. Now, if a patient does go on for cesarean delivery, the level should be cautiously achieved to a T6, and that is going to allow the patient to be able to cough in order to clear their secretions during the surgery. If general anesthesia is absolutely indicated, you want to be aware to avoid all nitrous oxide so that you can prevent rupture of bulla, and gases should be humidified, as well as thinking about frequent suctioning so that the patient's going to be able to clear those secretions. So let's move on to some of the autoimmune disorders and pregnancy. Specifically, we're going to be looking at lupus, antiphospholipid syndrome, autoimmune thrombocytopenic purpura, and myasthenia gravis. So let's start off with lupus. It's characterized by the production of autoantibodies against nuclear, cytoplasmic, and cell membrane antigens. The prevalence of female to male is 9 to 1, so it's not going to be uncommon for you to have a patient population in the obstetric unit who are going to have this diagnosis. Realizing that lupus can cause thrombocytopenia as well as hemolytic anemia, you really want to think about that as far as blood work before any kind of neuraxial anesthesia is done. So a preconception history of nephritis is going to help predict adverse maternal outcomes. So the risk of significant disease activity during pregnancy is actually increased 7-fold if active disease is present in the 6 months that precede conception. Realizing this, patients that have had a recent lupus flare should be encouraged to delay conception for at least 6 months after the disease has been quiescent. If lupus flares occurred during pregnancy, it's most common during the 2nd and the 3rd trimesters in the puerperum. Maternal systemic lupus impairs fetal survival, and it also increases the risk for preterm delivery. One study indicated that preterm delivery occurred in 39% of the pregnancies that were complicated by maternal lupus, and fetal loss related to lupus has decreased recently from 43% to 17% based on better disease control as well as better counseling of patients to avoid pregnancy during recent flare-ups. Neonatal lupus erythematosis. The autoantibodies are found in up to 87% of patients with lupus. However, the development of neonatal lupus erythematosis is actually very rare. So you want to think about things like pericarditis and tamponade, which are potential cardiac sequelae that clinically may present with dyspnea on exertion or unexplained tachycardia. You have to think about coronary artery vasculitis and accelerated atherosclerosis leading to myocardial infarction, and they may be exacerbated during pregnancy as well as during the delivery period. So you want to have an echo study in patients because you're going to see also a possible increase in valvular abnormalities, including valvular thickening, vegetations, regurgitation, and stenosis. Pulmonary hypertension should be considered and investigated if the clinical picture gives potential concern, since the prevalence of pulmonary hypertension increases as the disease progresses. In cases of severe pulmonary hypertension, abrupt sympathectomy and decrease in venous return may cause systemic hypotension and hypoxemia. Pleuritis is common, however, pleural effusions are rare. Lupus pneumonitis has fleeting hemorrhagic infiltrates that might become consolidated, so you want to be aware of that. Anemia, thrombocytopenia, and coagulopathy should also be investigated, as I stated earlier. Also, atypical blood antibodies might complicate cross-matching of blood for patients with lupus. In cases where blood loss might be high, time should be made to type and cross these units before they're needed. So let's move on to Antiphospholipid Syndrome. It's a prothrombotic disorder characterized by the presence of two autoantibodies, lupus anticoagulant and anticardiolipin antibody. Patients with SLE may show lupus anticoagulant about 34% of the time and anticardiolipin 44% of the time, yet antiphospholipid syndrome is a distinct and totally separate entity from lupus. One study indicated that about only 8% of the patients with antiphospholipid syndrome also had lupus. Fetal loss is related to placental infarction, and most of the fetal deaths that occur are during the mid to late pregnancy. It's a very tragic outcome for these patients. So management of these patients are going to include heparin, aspirin, and low molecular weight heparin. Women with APS and recurrent pregnancy loss should receive prophylactic doses for up to 6 to 8 weeks postpartum. In the devastating case of catastrophic antiphospholipid syndrome, or CAPS, it occurs in 1% of the patients with APS, and they have a mortality as high as 50%. In patients with CAPS and severe thrombocytopenia, rituximab may allow for platelet recovery. In patients that are managing their APS with aspirin alone, there is really no contraindication to neuraxial anesthesia, as we know. For patients that are on different anticoagulation regimens, including heparin and low molecular weight heparin, ASRA guidelines should be followed prior to neuraxial placement, removal of the neuraxial catheter, and dosing following the placement of the catheter. Moving on to autoimmune thrombocytopenic purpura, or ATP. The incidence of thrombocytopenia in pregnancy is 5% to 8%. However, the incidence of ATP is only 0.01% to 0.1%. So the diagnosis of ATP must be considered if the platelet count is less than 100,000. Other causes for thrombocytopenia should be considered. You need to think about gestational thrombocytopenia, preeclampsia, DIC, TTP, and acute fatty liver of pregnancy. So moving on to ATP management. There's really been no study that's been able to establish a platelet count that predicts the risk for epidural hematoma in the obstetric population. Although there is not a hard and fast rule, several experts have reviewed the available evidence and conclude that a minimal platelet count of 80,000 is usually sufficient for safe initiation of neuraxial anesthesia and analgesia and removal of a neuraxial catheter. Ultimately, though, it's going to be clinical judgment, weighing the risks and benefits of neuraxial anesthesia and its alternative, thinking about difficult airway and the risk of aspiration if general anesthesia is chosen in cases of cesarean delivery. In ATP management, you want to think about conservative management. Corticosteroids if platelet count is less than 20 to 30,000 at the start of labor or less than 50,000 at the time of delivery. IVIG also allows for rapid yet transient increases in platelets. And if conservative management during pregnancy is unsuccessful, consideration of splenectomy is made, but this is rarely done. So this is going to conclude our lecture today on anesthetic implications of selected medical disorders in pregnancy. We've talked about infection and sepsis and different definitions of sepsis and how to define that during pregnancy. We've also discussed respiratory and autoimmune disorders. Please, if you have any questions, don't hesitate to contact me, and enjoy your day.